To start off with the introductions, I'd like to introduce myself. I'm Shambhavi. I'm one of the national officers on public health this term, along with Aradhana. Aradhana, if you could just say hi.
Hey, everybody.
And we are part of this wonderful organization called Medical Students Association of India. We're a non-governmental organization of, for, and by medical students, founded in October 2011. MSAI is India's first both nationally and internationally represented organization for medical students, and we are a member of the International Federation of Medical Students Associations. As an organization, we strive to provide our members with numerous opportunities to become global health leaders of today and tomorrow, and this webinar is a striking example of that same intention that we do keep within ourselves. Ever since our inception, MSAI, we've spread our wings to the farthest corners of our country, and we continue to do so even today. We span over almost all states and union territories in India. And as of today, we've touched the lives of over 210,000 people in communities through our ongoing activities. And through our work for the welfare of medical students across the country and to enhance the healthcare system in India, we aim to make a difference together.
Thank you, Shambhavi. And a little bit about our standing committee. With a vision of a world where all medical students contribute to their full potential towards making healthier communities in their capacity, not just as students, but also as future healthcare providers, SCOF, or the Standing Committee for Public Health, primarily deals with the public health scenario in India. It involves functioning at the ground level, directly dealing with beneficiaries, and promotes medical students as the beacon of change, harnessing the grassroots level approach of public health. Our team specifically believes in focusing on holistic health in 5 primary focus areas: communicable diseases, non-communicable diseases, universal health coverage, health systems resilience and strengthening, mental health, and environmental health and climate change. And today, on the 28th of July, which is celebrated across the world as the World Hepatitis Day, which exists primarily for the awareness of viral hepatitis and inflammation of the liver that causes severe liver disease and cancer, we at MSAI have decided, considering the fact that infective hepatitis is a leading cause for liver transplants, we at MSAI bring to you with great pride and honor this webinar in collaboration with Organ India. And here, it is with great honor and great pride, we'd like to hand over the floor to Organ India. And Sunaina ma'am, if you'd like to take over.
Yes, hello everybody. So today's guest is a very, very special guest. His name is Dr. Sandeep Attawar, and he's the chair and director of thoracic organ transplants and assist devices at KIMS Institute for Heart and Lung Transplantation. He has over 27 years experience and is one of India's most experienced heart and lung transplant surgeons. His team has performed close to 540 plus thoracic organ transplants, of which 377 were double lung transplants, 117 heart transplants, and 57 combined heart and lung transplants in this period, with over 55 left ventricular assist device implants. Dr. Attawar and his team have currently performed 30 successful double lung transplants on patients with end-stage COVID-damaged lungs. This is one of the largest series of lung transplants for this emerging disease in the world. He is also an active member in the international cardiothoracic forums, such as the International Society for Heart and Lung Transplantation, Society for Thoracic Surgeons, and the European Association of Cardiothoracic Surgery. He is currently president of the Indian Society for Heart and Lung Transplantation. He was born and spent his formative years in Ahmedabad, did his medical schooling and specialized in general surgery at the St. KM School of PG Medicine. He further specialized in cardiac surgery at the Sri Chitra Thirunal Institute, Trivandrum. There's a lot more to say about him, but I have condensed it. Dr. Sandeep Attawar is a firm believer in universal access to quality care and outcomes in heart and lung transplants, striving to provide the highest quality of care to his patients at his institutions. And without further ado, Dr. Attawar, welcome.
Thank you so much, Sunaina. Good evening to everybody. It is really not just heartwarming, but it's very humbling. I am very grateful for this invitation I believe that given the day and the occasion, it would have been great to have a liver surgeon do the honors, or a hepatologist. But it is my great pride and pleasure to be able to ignite some level of enthusiasm in young minds. This has been something that has always been at the top of my agenda, to be able to speak to young medical students and probably open their minds to the options that are available in the field of medicine as they go forward. So today's Sunena, thank you once again for a very generous introduction. But today I kind of kept going back and forth in my mind, wondering as to what I should be able to speak about, and how should I go about this. But rather than talking about a long-winded, selective, kind of description of how physicians could fit into a large transplant program, I thought it would be better off to explain to you in a general sense about how a transplant patient goes through his journey of organ transplantation, and what are the challenges that we would face as physicians. It would start with a little bit of history. I would tell you about the early challenges that we went through in the field of organ transplantation, and the tremendous progress that we've made as a civilization in the last 50 to 60 years, and where we are now, at a phase and point in time in our lives where physicians are able to extend human longevity to beyond 100 years, simply because the advances that we've done in medicine, the levels of intervention that we've achieved in various facets or aspects of medicine, where there is lesser of invasive surgery and more of minimal invasive work happening in the fields of radiology, pulmonology, cardiology, to just mention a few. Gastroenterology, obviously, being something which is at the forefront of most of it, and urology too. The use of robots, and I'm still, trying to find my feet, trying to understand how AI will influence all of this going forward. But what's very important, when I heard Shambhavi and Aradhana speak earlier, I wouldn't at their stage of my career be able to string 5 sentences and make any sense at all. So what it also fills me is with a great deal of hope and a great deal of satisfaction to know that the younger generation understands the world around themselves better. They are in sync with what the needs of this world are, and they're ready to take over the reins and the baton of the future of medicine. With that I'll start. And it's important because most of you are physicians, probably on the cusp of graduating, some of you very young, just getting some initiation into the field of medicine. So I will just break it down in a simple way, and then we'll probably try to go up a few notches. So if you look at, like, you have genus and you have species. So we look at the species of organ transplantations, and the species would be either organ transplantation or tissue transplantation. Organ transplantation is generally solid organs, or probably intestines and limbs, pancreas, kidneys, hearts and lungs, and livers. Most of these are taken from a circulatory death donor, or brain dead donor. Now, circulatory death is a new paradigm or a new opportunity for us in the field of organ transplantation, but this is possible for us when we have a donor who has ceased his circulation, his heart has stopped beating, just within probably half an hour of the terminal event, and that's when we can probably still retrieve some of these organs and make use of them. However, tissue transplantation is possible, where you can retrieve corneas, bone grafts, tendons, cartilage, and skin from those organ donors who have probably passed away a few hours ago. The field is nascent, but it is growing in our country. However, it is fairly well established in the Western world. That's because they have an advantage in as far as years are concerned in the field of organ transplantation. An organ transplant involves explanting a good organ which has been assessed prior, from a deceased organ, from a deceased person who has been certified brain dead, and then implanting them into someone else who's been suffering from end stage organ failure, is very seriously ill, or is dying from that disease. Donors could be living related, closely related donors, where probably organs that can be partially resected and implanted, like the liver, or a kidney which occurs in pairs could be utilized to save a sibling or probably a family member, is when you can consider a living related transplant, or a deceased organ donor who could probably save up to 8 lives: two lungs, a liver, which could be split, two kidneys, a heart, pancreas, and probably the small intestine. Not to mention the tissues that could be retrieved, and also probably limbs in case the family decides to donate limbs too, and are not really considering the level of disfigurement that could occur with the donation. But however, what is very important is we all of us in the field of transplant medicine work around one individual, that is the recipient. This is a list on the left-hand side, which provides you an information about organs that could be harvested and transplanted. And on the right-hand side, you have tissue that could be utilized for organ transplantation. Just a brief about how medicine has progressed in the last probably 100 years, maybe 70 years. It's important for us to understand, and we must know that the human body has a limited vocabulary to declare the presence of an ailment. You might have a symptom like fever, or you might have a sign like a rash, or you might probably present to the primary care physician with persistent hypertension. But all of them are either signs or symptoms and manifestations of a deeper underlying disease. It could be anything. It could be anything from a connective tissue disorder. It could be an infection, and so on and so forth. So we as physicians work as detectives. And the job of our group is to be able to diagnose and treat all of these symptoms and signs by trying to gauge the illness that is probably causing them intuitively. And we've been doing this for quite some time. And thereby, many of our teachers and many of their predecessors have been using skill and judgment, and they've been using experience to be able to get through challenges early on in the history of medicine, especially when we did not have the levels of investigation that we have today. But at the other end of the spectrum, we have something we call precision medicine, where we are able to now have a precise diagnosis, and we are able to treat it with rule-based therapies, and we are predictably very effective in what we do. In between these two very ends of the spectrum, we have a large segment we call empirical medicine. And empirical medicine is something that we continue to practice, and we've been doing it for many years. Not that it is bad in any way, but the process of evolution is gradually taking us away more and more towards precision medicine, where we use minimally invasive or interventional investigations, which give us a understanding of the patient's health in greater detail, and we are able to do precision medicine in many ways. So empirical medicine utilizes probabilities and the art of pattern recognition. Scientific progress thereby takes us from intuitive to empirical, and thereby to precision medicine. And organ transplantation exemplifies precision medicine. And just a little bit about the history. As a transplant physician myself, I have seen it, I have experienced it, and I know it for sure that organ transplantations are transformative by nature. So when it started in the early 1950s, when we had living related organ transplants, especially in the kidney field, where we had recipients who were given organs by living related, very closely related, probably even a sibling who was a twin, we had very good outcomes to begin with. And that excited a lot of physicians in the field of heart transplantation, because we believed that this was something which was a great step in treating patients with end-stage organ disease. Later on, in the late 60s, heart transplantation picked up in a big way. And around the same time, in the year 1968, there was a clear understanding that there was a requirement for a brain death rule based on clinical neurological criteria, became one of the important brain death laws in all 50 states across the United States by a law called NOTA. And this allowed a slew of organ transplants to happen in the US. This was preceded by a lot of work in the animal laboratory for not just surgeons, but even physicians and scientists to be able to figure out how and what was the best way that this could be done. Having some initial success, unfortunately, it led to a domino effect where almost everybody was keen on on being involved in the field of organ transplantation, because there was a certain badge that of honor that you would earn if you were successful in what you do. But sadly, they did not realize that we were trying to fight probably over 1.5 billion years of evolution. Not really very easy. And we did not have much information either. So we had lots of early failures. We had mixed outcomes, and that led to a lot of disrepute to organ transplantation. And there came a time where there was hardly any confidence in the field of solid organ transplants, especially hearts, lungs, livers, kidneys, and so on and so forth. But in the late 70s and the early 80s, there was a miracle drug that was discovered, and the credit to it goes to a fungus from Scandinavia. And they found a drug and they named it cyclosporin. Cyclosporin change was a paradigm shift in the field of organ transplantation, because it was the first immunosuppressant which made a dramatic difference to the acceptance of the donor organ. We'll go into some details much later. Uh, uh, Cyclosporin, for that matter, resurrected organ transplantation, and then we had a resurgence in the field of heart, liver, lungs, and kidneys. Biopsies came in a little later. It allowed us to get into using a percutaneous needle, allowed us to get biopsies from the transplanted kidney, liver. We developed something called a cardiac bioptome that allowed us to take a small chunk of endocardial muscle from the right ventricle by gaining access through the right internal jugular vein directly into the right ventricle. We examined those slides under a microscope and looked at the level of invasiveness of neutrophils in and around tissue, and also the way that they would light up around small capillaries, which would give us something we call grades of rejection from 1 to 4. So grading of rejections made a big difference. And going on from there on, there's been a lot of work over the years that has happened in this. And now organ transplantation has become standard practice. Strangely, it's almost something that is conducted in over a dozen hospitals in every city in this country now, with unbelievably good short and excellent long-term outcomes in survival. Just to take you back and jog you through time, this is the picture of Dr. Christian Barnard, who did the first heart transplant in a hospital called Groote in South Africa at Cape Town many years ago, 1967. That was even before, a year before I was even born. He came on the cover of Time magazine, which was an incredible achievement, because he became a world-recognized figure. That was the impact of a heart transplant. And if you would ask me what would it compare to in current times, I could probably think of someone who had 50 million followers on Twitter, or probably an equal number of followers on Facebook and Instagram, for that matter. So this paved the way for us to actually look at organ transplantation as a solution for end-stage organ failure, not just in livers, as you can see in the extreme left-hand corner, heart in the center, kidney on the right upper hand, and a pair of lungs in the right lower corner. So what are the challenges when you're looking at organ transplantation? I would say there are two major challenges when you're looking at any kind of organ transplant. The first would be the blood group. And as we know, the O is the universal donor and the AB is the universal recipient. The reason I'm not mentioning rhesus here is because rhesus does not matter in organ transplantation. We are only worried about blood groups. And the reason I say that is because in someone who is of the blood group A, you have antigens sticking out of the RBC, and those antigens signify that red blood cell is of the A type. You also must remember that you have anti-B antibody circulating in that very same individual. So if you have a mismatched donor and you transplant a B organ in an A, I can almost assure you that what happens is going to be catastrophic, which we will call a massive hyperacute rejection. But this used to be the way that we conducted transplants till very recently, because now you will be surprised to know, and probably many of you are already aware of it, we do now perform blood group mismatched organ transplants. We are getting very good at it, but we are still not there. We haven't reached gold standard, but yes, it is a great step in the right direction, simply because it is almost impossible for us to ever reach a point where we will have adequate number of donors available in every blood group who would be able to save thousands of lives every year. So the O can probably donate an organ to anyone, and the AB can probably accept an organ from anyone. The other major challenge would be, like I mentioned, going forward in the previous slide, if you do a mismatched organ transplant, almost the first thing that you could happen, as you can see, those anti-A, anti-B circulating antibodies descend from the left side of the slide. They fix on to the antigen on the surface of the endothelial cell. They activate the complement cascade, and that leads to a further trigger of the neutrophil and the white blood cells, which act in various measures, not just producing pro-inflammatory cytokines, but also getting the formation of a membrane attack complex, which adheres itself to the endothelial cell, further promoting endothelial damage, which would obviously now recruit platelets, which would now go and stick to the damaged cell surface, using the von Willebrand factor, attracting many more of these active agents to be able to come and create a very firm clot, leading to a blockade of that blood vessel or capillary. And eventually, as that cascade goes around, it ends up with the organ being acutely rejected on the operation table as soon as it is perfused. This used to be a common occurrence very early on in the field of transplantation, till we realized what was really going wrong. We now understand very clearly that blood group matched organ transplants are the way to go, though we have found a way to circumnavigate or go around this problem. The other major issue is the human leukocyte antigen. So you would hear someone asking you, what is your tissue type? So this is primarily the sequence of genes that are on the human chromosome number 6, which decides your major histocompatibility complex. You have class 1 and class 2 in the human leukocyte antigen, and they are divided into 6 subtypes. The HLA class 1 has ABC, and the class 2 has DR, DQ, and DP. Now, if you're looking at a patient and a donor, it is almost unbelievably rare that you would have a perfect 12 by 12 match, where you have all 6 of them and in pairs match with each other. Almost all the time, you would have some degree of mismatch. The greater the degree of mismatch, transplantation is not a contraindication, but yes, your degree of immune suppression and the level of surveillance and monitoring needs to be of a higher grade. And that's one of the reasons why matching the human leukocyte antigen on both the donor and the recipient prior to a transplant are an important facet or an aspect of how you proceed with an organ transplant. This challenge can be circumvented in those organs which have a longer out-of-body time, especially the liver and the kidney, where your out-of-body time could be between 8 to 12, sometimes even as long as 24 hours, given the standard ways that we preserve organs. But with hearts and lungs, unfortunately, that's not the case, because the out-of-body time for both these organs is extremely short. The heart between 4 to 6 hours, the lungs between 8 to probably 12 hours. So all you need to do in this intervening period is to be able to figure out how you can match the donor and the recipient HLA, and make sure that you allocate that organ, the organ, to that recipient who probably has the best possible match. It only leads to better outcomes immediately after surgery, but also greater long-term survival, simply because many of these patients require lesser immune suppression, which by itself is a very toxic solution or a recipe for long-term survival, given some of the side effects that it has in the long term. Now, how does a recipient identify a donor organ at the cellular level? So the donor has an antigen presenting cell which circulates in the recipient circulation and is almost immediately identified by a naive T cell. This leads to progressive activation of many other T and B cells, especially the activated T cell, which then releases a generation of products. And B cells, when activated, start secreting, as all of you know and you've learned in your physiology, start secreting antibodies which identify and attack the donor organ. So our job as transplant physicians is to be able to achieve quiescence. We try to achieve something like an invisibility cloak on the transplanted organ using medications. Now, we generally would use three classes of drugs. The first being calcineurin inhibitors, which I already spoke to you about, which is cyclosporin to begin with. We have progressed on to many other newer drugs in this field, including tacrolimus. Then you have something we call corticosteroids, which all of you are aware of. High dose of steroids are utilized in some of these patients, especially lung transplant recipients prior to surgery, so that we can keep their primary disease under control. And then it's also utilized in the long term after lung transplant, simply because we can keep the graft going for long. And then you have cell cycle inhibitors, which are called mycophenolate and azathioprine, which are primarily working on the purine cycle. So they try to suppress T and B cell activity sequentially to be able to try to preserve graft function. And then you have some of these patients who've had multiple interventions, surgeries, blood transfusion, women who have given birth to multiparous women who have multiple childbirths, and all of these patients sometimes can have something we call a sensitized state, and that primarily means that they have circulating antibodies to the human leukocyte antigen. Now, if you have a donor who probably has some of these antigens that already have preformed antibodies in the recipient, then it's a recipe for disaster, because you would probably have very early rejections. You could have persistent rejections. You could have rejections that are very hard to control, will require or necessitate longer ICU stays, a lot of expenditure. These are things that we can avoid. And these are things that can be treated beforehand. So what would you do? You would either dilute the circulating antibody against the HLA, or you could probably even eliminate them. The way to dilute them would be transfusing them with immune globulin, human immunoglobulin. The way to eliminate them would be to run them through a machine that you can see on the left-hand side of the screen, which irradiates using a collected blood from a patient, primarily plasma, with ultraviolet rays, which destroys those B cells that produce those antibodies, while immunoglobulin dilutes them. So photoreactive therapy allows us to be able to perform many miracles in the field of organ transplantation. And eventually, what is the purpose of all of this? Our purpose is to be able to maintain adequate balance of both immune suppression and prevent rejection. Now, over immune suppression can lead to infections. It could also cause blood-related cancers or lymphoproliferative disorders. High doses of immune suppression can cause side effects like hypertension, diabetes, which are drug-induced. It could also cause, tacrolimus could cause kidney damage and many other side effects like hair loss, tremors, so on and so forth, which may not be lethal, but can be significantly disturbing for patients and affect their quality of life. Likewise, if you're looking at under suppression, then you could end up with rejection. And that could be at various stages. You could have an acute rejection, you could have a chronic rejection, you could have multiple acute and chronic rejections, which would eventually lead to organ degradation, which would eventually lead to either organ failure very early on, thereby leading to a limited lifespan, requiring probably a retransplantation, which is not going to be easy, and sometimes even leading to death. So when you're looking at working as a transplant physician, you must understand that this field entails, like I said before, it entails microbiologists who are looking and surveilling for infections. You're involved with primary physician who may be either a pulmonologist, a hepatologist, a nephrologist. You're looking at surgeons who are trying to implant organs surgically after retrieving them from remote locations, traveling long distances. You're looking at anesthesiologists, intensive care, pathologists, immunologists, and all the supporting, what would I say, specialties, right from gastroenterology to endocrinology, infectious diseases, and so on and so forth. So it takes a village to perform a transplant. And all of that is required is great communication. In medical school, unfortunately, at least this is, I can speak for myself, we came from a generation of students who were taught to excel right from grade 1. We were taught by our parents to always stand out in the class, to come first, simply because we would be at the top of the pile. We would get the best opportunities in for education, and we would always ascend in the social hierarchy, where would be alphas. That's unfortunately the ethos or the training that all of us get when we go through childhood and then early adulthood. But unfortunately, in transplantation, we have to unlearn all of this instinct. We have to understand that at the center of all that we do is going to be a very sick, ailing patient and his very disturbed family. And a transplant physician stands at the junction between a point where you have someone who has prematurely met his very tragic end, a family which is dealing with grief, has to make a very difficult decision, something that they've never thought about in their lives, but to be able to look at their loved one continue to live in probably 8 or 10 other individuals going forward. A tantalizing prospect, but very, very difficult one to probably accept or even undertake. To go through the same trauma of organ donation subsequent to their loss, and then on the other end of the spectrum, you have a recipient who's waiting very hopefully with end stage organ damage, living every day in the hope that he will probably have a new lease of life. Not very easy. So we stand at the junction of two very difficult sets of people, somebody grieving and another very hopeful. And it's not easy for us because most of these recipients are really, really, really sick and they have multiple problems. So to be able to make a difference in their lives and to get them back on track is a monumental achievement. And I think none of us as physicians could take individual credit for it. All of it is possible if we work as a team. I probably hope that this gives you some understanding of how involved one must be and how it allows you to amplify everything that you've learned all throughout your training in medicine to be able to now bring it into practice. Because as a cardiac surgeon, I performed over 10,000 heart operations on adults and small babies over a period of nearly 25 years before I realized that it was something which was so predictable and so mundane that I actually started looking out uh, uh, for a bigger high, something that would be kind of a real challenge. And I found that transplantation truly exemplified that challenge. Just imagine a heart and a lung have a very short body out of body time, and to be able to explant a donor organ after assessing it, bringing it over to your center, uh, managing logistics in a way that the recipient's chest is open, you're able to explant his diseased organ, implant a new one within 4 to 6 hours, to be able to reach international standards. Likewise for the lungs, is like working in a Formula One team. Great teamwork, coordination, understanding, appreciation of everyone's contributions are exceptionally important. And in spite of doing all of this, we would probably be able to save 8 out of 10. We would never get a 10 on 10. And we would lose patients in clusters. In spite of everything going right, we would still lose patients. What's important to understand is cold preservation, which has been the way that we continue to store organs until very recent times, has now faced a major challenge because while you reduce the metabolism of an organ on ice by 12 to 13 fold, it's important to understand that it is very difficult to dynamically assess an organ that has been retrieved by someone else who probably doesn't have the same level of experience as a transplant surgeon would. And then to be able to expect an outcome is probably not reproducible in every environment across the world. So it's very important to understand that we needed better ways and means of trying to not just store organs, reduce the amount of injury caused by ice or extremes of temperature, which we call thermal injuries to the organs, prevent organs from moving around in an ice box, undergoing physical damage, the interactions of certain segments of that organ with solid ice can sometimes be seriously detrimental. And Also trying to probably move a bit forward and looking at something we call dynamic machine perfusion, where you put a heart or a lung on a machine and perfuse it with nutrients and blood from the donor, which is or O positive blood from the blood bank. See that heart reanimate or the lungs start breathing again, and then you have a host of analytical tools available on the platform, which will tell you what is the PF ratio, what is the ratio of inspired oxygen to what the lung generates. If it's more than 300, then it's a great organ. If you see a heart beat really well, generate good blood pressure, and you also see the lactates that come out of the coronary sinus, which are acceptable, then you know this heart that came out from a donor who had sustained a cardiac arrest half an hour prior to the organ being retrieved is now perfect and good to go. You could probably save that organ and save a life. So what we have achieved in the last probably a decade or decade and a half is being able to not just expand the donor pool, but also optimize those organs which at first glance would probably not appear suitable enough for organ transplantation. Going many steps ahead, we are now able to perfuse some of these organs with a cocktail of antibiotics and antivirals and antifungals, because as all of you know, most of these donors, brain dead donors, either have had a stroke or have had a vehicular accident, are lying in an ICU for a week probably, with all kinds of interventions having done on their skull, probably have had a small bout of infection, have IV lines, have multiple people handling these lines. So you can't take an organ from a possibly, potentially mildly infected donor and then expect a great outcome in a recipient who's been immune suppressed. So perfusing these organs with antibiotics, antivirals in supratherapeutic doses, because on a platform, when you perfuse these organs, you do not have to worry about a kidney getting damaged because of a high dose of gentamicin, or probably a liver getting damaged because of a high dose of minocycline. You could use bacteriophage therapy. As you know, bacteriophages are the only solution going forward. We have reached a point where none of the current available antibiotics are effective against some of the most virulent multi-drug resistant bacteria that are circulating in our hospitals. So bacteriophages are utilizable on perfusion platforms. We can use bronchodilators, surfactant therapy. We can do endoscopy or bronchoscopy and clear aspirations, gastric aspirations. We could use fibrinolytics to dissolve pulmonary emboli and kind of retrieve or recover that lung. We can dehydrate using high oncotic pressure perfusates to be able to improve the oxygen capacity and the carrying capacity of that lung. And we can use membranes and filters to reduce the degrees of circulating cytokines. And the last, couple of slides, what is probably very interesting is the almost limitless option or endless option of organs that can come from a parallel source, not human beings alone, because we know as the world becomes a safer place, the number of donations are obviously going to continue to stay limited as vehicular accidents come down in number, and as medicine progresses and gets better in trying to treat patients with severe strokes too. So xenotransplantation, as you know, is in mythology, is in history. You've read stories about it. I'm sure you've seen the X-Men. You've seen somebody who probably has characteristic of features of even stronger beasts or animals. The Lamassu is one that comes from mythology. The Chimera is a combination of three different creatures. Likewise, when we take an organ from an animal and use it for transplantation in humans, the potential impact is immense. Not just because we can save lives with organ transplantation, but we can always utilize it for tissue and cell transplants. So currently, our direction, as far as science is concerned, is looking at xenotransplantation, utilizing pigs as donors. We have begun with hearts and kidneys. As most of you are aware, there have been a couple of hearts and kidney transplants done from lab-grown pigs. But xenotransplantation eventually will play a tremendous role. in diabetes mellitus with pig eyelid transplantation, in Parkinson's disease with neuronal transplantation, which could alleviate symptoms of Parkinsonism. You could use RBCs, an alternative for transfusion medicine. You could decellularize a pig cornea and recellularize it with autologous keratocytes. You could use modified hepatocytes for congenital liver metabolic abnormalities. You could use them in ex vivo organ perfusion devices to be able to reduce the bilirubin in patients with severe hyperbilirubinemia. You could use pig skin for the treatment of those patients with severe burns. The question is, why pigs? And that's something that I will not go into too much of detail, though this is an area of extreme interest for me. We are looking at 80 million years that are the evolution gap between pigs and us. However, they seem to be probably the most logical choice that we can have, given the fact that they can be bred. Their breeding cycle is short. They have multiple sow. The sow can lead to give birth to multiple piglets. They can be culled when they are of the right size. They have many anatomical and physiological similarities. You could probably even genetically modify many of them, because most of them require induction of human transgenes and the removal of certain carbohydrate moieties in their not just endothelium but also their red blood cells, which can allow us to let them inhabit or live in the human environment. We also have something we call CRISPR, or CRISPR-Cas9, which is basically a molecular scissor, which allows us to delete certain segments of pig DNA which encode intrinsically for the porcine, multiple variants of porcine retrovirus, endoretrovirus. And we can do this by multiple methods while we rear them in circumstances that can be completely controlled. So that ends my kind of long winding introduction to what transplant medicine can do, what it has been doing, and what are the opportunities. I'm sure all of you, being intelligent young children, kids who would probably understand the opportunities that are available for you. But it's also very important to understand that if you are an orthopedic surgeon, you could use tendons, you could use cartilage to reconstruct an ACL, you could use bone grafts and prevent limb amputation. As an ophthalmologist, you could probably treat corneal blindness. As a diabetologist, you could probably look at ways and means of a kidney pancreatic transplant, which could probably not just treat the kidney disease, which is caused by long-standing severe diabetes. So there are multiple ways and means that anything that echoes with you and your kind of vision for what you would like to do yourself, transplant is an opportunity for every one of you. So with that, I'll end, and thank you so much for the time.
Thank you so much, sir. Thank you for that session. It was deeply informative and enriching for each and every one of our participants. I'm sure everybody has gained a lot from this. And now we'd like to take the opportunity to open the floor for questions. All our participants who've been listening with so much intention and curiosity, we welcome you to drop your questions either on the chat box, or you can raise your hand and we'll take your questions. We'll be leaving the floor open for a while so that you can curate your questions, but we invite all of you who are interested.
And while our participants and our audience readies their questions, so we do have some questions that came in through the registration form that we released. And I think we can start with those first. So the first question that we do have, sir, is in your experience, how different was your education and your academic journey from your peers in medical school?
That's very interesting, because when we started, I guess many years ago, I can scarcely remember any exposure to organ transplant at all. In fact, when I started, I was not even privileged to have any exposure to even being exposed to something that I ended up doing, heart surgery. Heart surgery used to be, the bastion was probably Chennai in those years, the late 80s or mid 80s. It used to be Chennai and Bombay to some extent. Delhi had the All India Institute, which was doing some pioneering work in heart surgery, and that was about it. There was literally no heart surgery in this country. And however, we used to hear about heart surgery, and we used to see heart surgeons, and there was a certain glamour element around that time that was associated with heart surgery, and probably some of those things. And there's a warning for all of you, because however eloquent or impressionable or however impressive or charismatic a speaker may be, or the people that you find in your surroundings as young physicians, it is very important to reflect deeply on your choices and not to get carried away. That is vital, because thinking about your career choice is going to make a fundamental difference to how you're going to continue to inspire yourself to do something that you have to do day in and day out. Medicine is only getting even more and more challenging. We were very fortunate. We did not live in the times that you guys will step into. You are going to be faced, uh, to to say the least, probably WhatsApp University and Google, because I find it disgusting and distasteful when patients and their families come up with loads of information from nonsensical sources. And it's very important to understand that in medicine there is nothing linear. If there was something linear and we could have a causality attributed to every action that we did, it was so easy. But to be able to understand this and work in a non-linear world, and then continue to probably strive to achieve, what would I say, good outcomes, reproducible outcomes consistently, is not just mentally exhausting, it is physically very draining. It can affect all your relationships, it can affect your friendships, it can affect your family life, and especially when I look at the toll that it can take on your families and your children, it's not going to be easy. And so I genuinely believe that I'm lucky. I'm towards the end of my career, and I feel so filled with morbid kind of what would I say, fear when I look at what youngsters would have to face. But there's also a great deal of hope, because you are going to enter that generation, or that new vista in medicine, which we could only dream of. You will have more information. You will be targeting therapies in a different way. You will have definitive ways and means of dealing with the problem. And while human beings won't change much, you will have continue to have the same challenges that we do, but I think you will be in a better space. So I have a lot of hope for all of you. And I think there are many more opportunities that are turning up in medicine. I'm increasingly seeing surgery take a back step, and I see physicians being able to do multiple things. So when I became a surgeon, I probably became a good carpenter, probably a very advanced plumber, because that's all I do. But I truly have a great deal of respect for my medical colleagues, who are like detectives. You understand what needs to be done, and they're able to tell me exactly whether this candidate is ever going to be a transplant candidate at all. I do not understand immunology as much as they do. I do not understand medicine as much as they do. I do not even remember the dose of antibiotics or immune suppressants. All I know is this is the drug that needs to be used. But then I do what I do best, right? So, but increasingly I notice that a cardiologist can put 3 stents and avoid open heart surgery or a bypass operation, something that is such an invasive procedure. If you ask any one of us, we might want not to undergo a procedure which opens our chest and requires veins and arteries to be stripped from all across our body. So medicine is getting better. I think it's getting more predictable. I think it's getting more precise. And I believe truly that you live in a generation that will define probably the next 100 years of what can happen. Yeah.
Thank
so
you so
much for
much for
that,
that.
sir.
Right. And just picking up from there, we also had one question that sort of like, since you concluded on the part of evolution of medicine and the direction that we're heading in, we had one question from a participant about to know about how exactly the field of transplant surgery has evolved since you began your career, and especially how do you think the advancements in artificial intelligence and robotic surgery, how do you think they will play into shaping the future when it comes to transplant surgery?
Well, I probably can answer part of the question because the remaining half I really don't know. I think the worst thing that we can do is probably use our position and our experience and predict, because predicting the future is very difficult. It's almost impossible. And however good you are at what you do, there is no way that you can predict what will happen in the future. But yeah, I can clearly see that it is going to be better than what I can even imagine. So that's the first part. The reason I say that is because when I started transplantation a decade ago, and I gave up performing heart surgery, the first thing that I noticed was there was a growing number of patients, even the ones that I had operated, who probably would have done better with a transplant. I performed heart surgery on them for advanced valve disease or probably nearly inoperable congenital heart defects, simply because there was no option of organ transplantation. So, in my view, I think if you're trying to if you have a hammer, everything appears to be a nail, and I don't think that is the right approach. There are patients with incurable heart diseases, with end stage liver and kidney deformities that are continue to be treated, or I would say ill treated, mistreated by physicians across the world. And I wouldn't say our country, across the world, simply because they are either unaware of options that are possible, where you can give these patients a better quality of life, pound to pound, rather than spend the same amount of money or multiple interactions with physicians, spending tons of money trying to treat an incurable condition, where a transplant would probably have been a better option in the first place. So I think it's very important that we are cognizant of the fact that we must take every disease and its extent, not just as individuals, but have some level of interaction with physicians who have a slightly deeper understanding, or can bring in new facets of how you would look at that problem. So I think that is very important. It is also important to learn to say I do not know. It is also important to learn to say that I don't think so and I don't know. Because if you tell yourself that you are the answer for it all, then I think you will never get better. And I think that one individual who trusts you for your professional opinion will do so far worse than what you would want him to do. And I think that is the first fundamentally important thing. So realizing that we can do better for our patients is the first aspect. And once you do that, I think it opens up your mind to multiple possibilities. Questioning yourself is the first most important thing to do. And we are very fortunate because a transplant surgeon, is a very glamorous role. My interaction with a patient is very short. They believe that I'm going to transform their lives, and which is actually not true, because I perform probably, yes, 20% of their entire treatment paradigm. I perform a very difficult operation, which I do not disagree requires a lot of time, patience, it requires a lot of coordination, but I am trained to do that. That is something that I have done hundreds and thousands of times in the past. So I have a method to do it, and I as well better be good at what I do. However, when I look at my physician colleague, he doesn't have the same challenge every time. He has a new challenge every time. I have the challenge of stitching a couple of tubes to each other. I just have to make sure that they don't bleed. I have to make sure at the end of the operation, everything's looking fine. There's no narrowing happening, and everything is good. I close the chest, and the patient's out in the ICU. Once he wakes up and he's passing good amount of urine, and everyone tells me that okay, he doesn't need many inotropes, I say, oh, job well done, I'm great. So family says, "Arey sir, aap Bhagwan hai." But that's just the beginning, because then my friends, my colleagues in intensive care will be dealing with a GI tract that doesn't move on time. They'll be dealing with the bugs that are appearing in the bloodstream. and they will only work on information that they do not have. A blood culture would probably give them information 3 days later, while they already have high grade fever and they have leukocytosis. They have dropping urine out. So for them, I think it is a more difficult task for my medical colleagues, and I truly respect people who do a job in very difficult circumstances. Answering a question, "Arey sir ne to acha operation kar diya, ab kya ho gaya?" So these are challenges and questions that everyone will ask, and it is not untrue. And you as students would face situations where the surgeon says, "मैंने तो अच्छा ऑपरेशन कर दिया, लेकिन मेरे को क्या पता क्या कर रहे हैं ये लोग, पता नहीं क्या कर रहे हैं." So plausible deniability, trying not to take responsibility for what we have done and probably we are part of, is part of our culture as a human race. We do this all the time. It's important to owe up, and that's the most difficult thing to do. But patients will respect you for that. When you tell them, "I do not know, we will wait for more information and we will try," I think that is what is important. So, while this, I do not want this to be a long-winding conversation only about organ transplantation. It is my great pleasure to be able to tell you exactly how I feel when I'm 35, 40 years ahead of you in the field. I wish that all of you imbibe this, kind of ethos very early on, because it will get you where I am after so many, much, much earlier. You will be much better than what I am. And that's exactly what I want you to do, because however hard-nosed you are, or however much pride you have about topping your university consistently and being the top ranker, it makes no difference in the real world. All the difference is going to be how you're going to be interacting with the environment, and how tolerant you are towards your colleagues, and how receptive you are to new information. How easy it is for you to be able to question yourself and relook at your decision is going to make all the difference in how successful you will be. And as you get better, you will realize that there are very few who can match up to you, because this is more of being an intelligent, perceptive individual rather than being a very successful physician. So please encourage yourselves to do more of this, to question yourself, to tell yourself that, maybe I did a wrong thing. And I can tell you, if I lose the feeling that, I have done a great operation and the patient did not go home, it doesn't really matter. And I don't ask myself, why did this gentleman not survive? Why did he not go home after a transplant? If I stop asking that question to myself, and if I do not curse myself endlessly in my thoughts, and when I'm thinking about it, I don't discuss it with my colleagues, then I don't think I'm doing the right thing. So never give up questioning yourself. You have to ask yourself, why, or what did I do wrong, or how could I have been better? That's the only way we can take medicine forward. Yeah. I don't know. I probably deviate from the basic question, but I hope I can.
Thank you so much, sir. That answer was very profound. I think the wisdom that we've all been able to imbibe from it is it's wonderful. And I think the way that you the humility in your answers is something that we all can take as an inspiration.
Thank you.
We do have a few more questions in the chat, and I think the general theme in, I think, 2-3 questions from Naman and Shivani and others is how the career pathway proceeds. There are people who have interest towards cardiac and transplant surgery and want to know what are the pathways available for an aspiring surgeon, and how, as an MBBS graduate, we can gain experience in these fields.
So once you do your bachelor's in medicine, obviously, I believe, unfortunately for us, everything depends upon how well we score in our first, second, third year, or whatever you talk about. And then, unfortunately, some of these exams which have no bearing on your skill or your ability, and exams that can be manipulated. Sadly, we've seen it in the very recent past, lead to a great degree of kind of sadness and a lack of enthusiasm. But it's very important to understand that transplant medicine is all not about being an operation or being a good surgeon. Well, some of us have great interest in surgery, and we would love to do an operation ourselves, because that's the most tangible difference that you can make in recipient's life, where you're physically trying to change his destiny. What is so incredible is you are able to extract an organ which is damaged and put in a new one, and see it functioning. I mean, there is no greater high than that, I can tell you that. To see a heart beating, where you've seen a very flabby looking heart inside a young boy's chest, and then you look at a really dynamic pulsating heart after a transplant, there cannot be a greater high. When you see a kidney that starts producing urine the minute it is implanted, the recipient who was on dialysis wouldn't pee more than 100 cc's per day, or probably 100 cc's once every 2-3 days. You see him pouring urine, there cannot be a greater kind of satisfaction. But that's only the beginning, and that's not the end of it all. Even these patients do not do well. But what is important is a physician who probably continues to monitor these patients really well, has a good deal of communication happening between him and his family, the recipient's family, and the recipient himself, convincing him that regular therapy, monitoring, surveillance are going to be key, determinants of his long-term outcome. Making sure that he spends the same amount of time year after year, and seeing this recipient come back and see him in his clinic is going to make a great deal of more satisfaction to an individual than a surgeon who's probably stitched 3 or 4 tubes and moves on to the next operation. So if you want to be a transplant surgeon, you probably have to do your bachelor's, then you go through your general surgery, and then you get into heart surgery. And then unless you've spent a lot of time in heart surgery, looking at and understanding the backgrounds of what you would do and how you would deal with the mechanisms or platforms that allow circulation or maintenance of, or preserve the human, preserve life while you're operating an organ which is supposed to be beating 1 million times a day and probably 2.5 billion times in a lifetime. You just quieten that organ and then keep repairing it, and then get it back to function, and then support the heart is a stupid organ, if you ask me. It is just a pump. It doesn't secrete any enzyme. It doesn't do anything. But you can live without a limb. You can probably live with one kidney. You can live with half a liver, but you cannot do without a heart. And especially with a failing heart, you just can't do anything at all. So while every single organ has its own, I would say, its own importance, I do believe that transplantation now is more predictable and has greater kind of long-term outcomes, especially when you're looking at the fields of liver and kidney transplantation, liver being the best. And it is no surprise that while kidney transplantation continued to rule the roost for nearly 2 decades, from the 80s till probably the early 2000s, liver transplantation since 2007 has become widespread. It's almost as common, even commoner than kidney transplantation. And you have better outcomes. You have longevity. You have recipients doing much better, because it is an incredible organ to transplant. It is highly tolerant. It is highly tolerant to the travails of an operation, and it kind of takes over the function almost like magic. Not as much for the hearts and the lungs, but the secret in all of it is that being an organ transplant physician is probably somewhere or a decision that you make somewhere in the middle of your career. You cannot target to be an organ transplant physician. While it is a great target to have, but it is a long and an arduous path. It's not very easy. And you are highly dependent upon the environment that you function in. If you are in an organization or a healthcare system, or you live in a city that has access to not just advanced testing, but also a great deal of support with labs and so on and so forth. If you're a heart or lung surgeon, unless you live in a city which has great connectivity, which has airports that have multiple flights coming in and out, you cannot expect to have organs, especially except from the local community, which are going to be very few. And unless you consistently do more than 30 or 40 transplants annually, you're never going to be very good at it. So making your decision that, oh, I want to be a transplant physician, even if I do 5 a year, is not a very sensible one. It's easier for you to probably do that in the United States, where you have 4.5, 5,000 donations happening every year. For a country like ours, 1.4 billion, we still have only 1,000 donations a year. But let me tell you that it is changing dramatically. And it's not going to be very far where in probably the next decade, I would probably see between 10 to 15,000 donations annually, which is an incredible number, which will lead to an explosion in the field of organ transplantation. Because you look at the recipients now, what's happening, what is changing in this paradigm. You're having more of us who are getting older, who are being treated with medicine so that our diabetes is under control till we are in the 60s or 65, 70. And then you have end-stage kidney disease. And then what do? You need an organ transplant. Now, at that stage of your career, you've earned well enough for yourself, and you believe that you want to live longer, you want to live a quality of life. So you want an organ transplant. You actively pursue an organ transplant. Now, if you don't have a donor from the community, then you have to look at a living related. So somebody from your family has to donate, which is not an easy decision to have. So unless we have deceased organ donations, which happens in evolved societies where you have more organ donors, like what Sunaina and her organization are trying to do, unless we expand the field of where deceased organ donation and pledging and people coming forward to donate organs happens, I think it will be very difficult for us to continue to expect that we'll have, one of our relatives or loved ones sharing one of their organs with us. And I don't think it makes sense in any way, So even as medical students, I think it's very important you go out in your communities and talk about organ donation, because that is the true solution. As we realize and we see that you're going to have many patients with heart failure. For example, I have triple vessel disease today. Now the cardiologist puts 3 stents. I have a blocked stent after 8 years. He tries to open it up, doesn't work. I have a infarct. Then somebody says, okay, ab to surgery karni padegi. Then I have a bypass surgery. I've taken another 10 years down the line. But then eventually my heart is going to fail. And when it fails, I'll have a pacemaker. I'll have rhythm management. Somebody will say your mitral valve is leaking. They'll put in a mitral transcatheter mitral valve. Somebody else will tell you now your aortic valve is narrow. Let's put a TAVI. So after all these interventions, my heart will still fail. And when it fails, I need a transplant, or I need a mechanical implement which will support my heart, like an LVAD, a left ventricular assist device. So that's another option. But if I'm a 75-year-old gentleman and I cannot tolerate a blood thinner, then a heart is my only option. And if I do not have a heart, yes, can it come from a pig? So there lies the question, So, but having said that, the field of transplantation is just exploding, and it is probably one of the fastest growing fields in medicine. And the surprising thing is, even if you're a urologist, yes, transplantation can be part of what you do. If you're a cardiologist, yes, you can take care of patients with heart failure, and you may be involved in the care of some patients after a heart transplant. If you're a surgeon, a heart surgeon, obviously you will be involved in transplantation. So it is always going to be a part of what you do, whether you're a physician or a surgeon. But always remember that once you get into transplantation, or you get the taste of transplantation, I can tell you, for all those very intellectually kind of driven individuals among you, it is like a drug. It is like a drug, because once you taste it, you cannot do without it. It takes your skill, it takes your mental acuity, it takes your level of understanding and thinking to another few notches up. So I would encourage all of you to seriously think about careers in organ transplantation, whatever they may be. But during your passage, your rite of passage, or the time that you spend in medicine, every single opportunity that you get to understand how we can beat 1.5 billion years of evolution, please, I would encourage all of you to try. It is very exciting as a field. Sunaina, I've taken a lot of your time. Please forgive me for that.
Not at all, not at all. Everyone's been really enjoying it.
I think so we could maybe take one more question if we have the time, Sunaina ma'am.
Sure, absolutely. I have all the time.
So in the chat, there are a few people, I think Prathamesh and Shreya, and we've gotten a lot of questions on tissue culture and 3D printing. So I think as the new generation, we're all interested in the
I'll tell you a very interesting story. So there are many hearts that are not taken. There are many livers that can't be taken, and there are kidneys also that can't be taken. Now, Now, what do you do with this? Let me give the heart as an example. So if I have a donor heart that unfortunately is not in a state of function that it can be used for an implant, I could still explant this heart. I could take valves from it. I could explant the pulmonary valve. I could explant the aortic valve, and I could use it for an individual or a young child with a valve defect. I could repair that defect with a autologous heart valve, and I could give them a near perfect life. But I could also do this. I could take that to the lab and I could decellularize that heart. So what do you do? What do you mean by decellularization? You run a detergent, if using a common term, detergent through the aorta. You perfuse the coronary arteries, and what it does, it strips away all myocardial cells. It strips everything away, and all you're left is that leaf that you put in your book. After some time, you can remember there's a diaphanous membrane. All you can see is the network of fibers that hold that leaf and the cells of the leaf together. So you have something called a skeleton, a bioskeleton. Now you can actually take, if I am that recipient who needs a heart transplant and you have a bioskeleton lying in the lab, I have my epidermal cell, which is taken by skin biopsy 3 or 4 months in advance. I can take it. They can take it in the lab, and they will reverse engineer my epidermal cell, and they create something called IPS cell. That is a forget the full term, induced pluripotency. So I induce pluripotency, and I can make this induced pluripotent cell into any cell I want. I can make it a hepatocyte, I can make it a Purkinje cell, I can make it a cardiomyocyte, I can make it an atrial cell. I can do whatever the hell I want with that cell. All I need to do is use specific tags and then allow it to go and repopulate that specific zone in the bioskeleton. So I can repopulate every single cell in that bioskeleton, and I can create a new human heart. The challenge does not end there. The challenge ends there is because this new heart resembles a good new heart. The problem is I need to get it to work in synchronicity. If that heart doesn't beat in a synchronous fashion, then it's never going to be able to sustain life. It will never generate blood pressure. So what I do is I now put this heart in a bioreactor. The bioreactor basically induces coordinated contractility in the heart muscle by increasingly giving it resistance in the aorta and the pulmonary artery. Over a period of time, using electrical impulses, I can get this heart to beat rhythmically, coordinate the atria and the ventricle, and eventually get the cardiomyocytes to generate at least 60 to 80 millimeters of mean arterial blood pressure. Now, this is being done in the labs. If and you will be surprised to know that it's being done in the labs. The only challenge is we need hundreds of liters of solution. We need bioreactors. We need men. We need workforces. So every single human heart that we have to create this way would probably cost us a few $1 million, one heart. So while it is theoretically possible and we have the technology to do it, it is physically possible too, but we do not have the resources to get there. Actually inject liver in a peripheral bloodstream, it can go into various pockets in your body, and you can continue to do what the filtration of bilirubin has required. It can produce insulin. It can take care of most of what you need to do. But importantly, I think there are so many facets of bioengineering that you can, especially with hearts and lungs. But as far as 3D printing is concerned, yes, we have 3D printers now that allow us to create. We have bioglues, we have biomaterials that we can print. We're able to create a strip of heart muscle. We're able to get it to beat too. But to be able to do it in a bigger fashion is probably still something that is work in progress. It'll take us some time. So that's why we believe that before we have bioengineered organs, especially difficult ones like the heart, I think we might probably have livers, we may have kidneys, we may not have lungs, but we'll certainly have, what would I say, we will certainly have subsets like probably artificial corneas by decellularizing corneas from those that cannot be used. we can probably have many other things available in the next few years, especially skin grafts. And if we have skin grafts that are available, you can imagine the number of burns patients that we can save. So, and there are many new avenues coming up in medicine. When we were there, we had a cardiologist. We did not have an interventional cardiologist. Now you have interventional cardiology, and now you have structural cardiologists, and then you have electrophysiologists. So every facet of medicine is now growing with time, and you have newer opportunities, and you have newer roles to kind of fulfill them opportunities. And we're also entering a very flat world. There is now coming a time where the West is on somewhat, I would say, a decline. A decline not simply because their resources, they're running out of resources. Countries like India and China are really filling that gap because we have a much younger population. We have the advantage of being on a level playing field as far as knowledge is concerned, and now we have AI. So eventually, what is important is motivation. And if we have people with motivation, we eventually will end up. And if you look at the physician community in the United States, just to give you an example, and all of you might know, an American would generally prefer an Indian physician to treat them. You'll be surprised, and I'm sure many of you know that. That's simply because of the way that we function, the empathy that we have as a race. Sometimes when we practice in our own country, we forget it, but I think that is competition. That is an abundance of human beings per square kilometer that creates abnormal work pressure on most of us. But it's important to understand that given the right opportunity and the right conditions, Indian physicians have excelled anywhere in the world. Excelled anywhere in the world, because probably it is the challenges that we go through, and especially women, because I think they, as surgeons, they have nimble hands. They're able to do more delicate work, and more importantly, because of a gender bias which has been existing for hundreds of years, I think women are more tenacious. They have a higher fighting spirit. They have to overcome challenges not just at home, but they have to prove themselves in a perceivably male-dominated world. So, and increasingly, I notice I'm seeing a lot of women taking up roles in medicine. There's a sharp decline in the number of men in medicine, and that's very welcome. It's very welcome. I believe that women have more empathy. They have, and I wish that they continue to be that way, because that can change too very quickly. So empathy is very important, and knowledge, intelligence, I don't think doesn't favor any gender, but the tenacity and the aggression that many young women show in trying to excel in adverse situations is something that will fuel, their passion to be great doctors. Yeah.
Right. Thank you so much, sir. And thank you so much for all these inspiring words. And I believe we have overshot the time. So we apologize to the participants whose questions we cannot take, but we will certainly make it a point to email it to sir and have them address. Have your questions addressed to the best of our ability. And yes, I believe that brings us to the conclusion of this webinar. From exploring the basics of transplantation to delving into the various cutting-edge technologies at the precipice of a medical revolution in this field, from career pathways to the ethical dilemmas. Sandeep sir, we thank you so much for conducting such an extensive and illuminating webinar. And we are even more grateful that you took out so much time and with so much patience fielded all the questions that we had, at least most of them. And it has been a true pleasure and an honor to have you join us. And I'm certain that a lot of our participants present here will have been inspired to take up a field in the career of transplantation. So thank you very much for joining us, sir. It's been wonderful having you here. And of course, as I proceed to thank, we would very much like to express our gratitude towards our partners, Organ India. We thank you for facilitating this webinar, and Organ India has been working relentlessly to spread the word through all of social media and through all media to organize awareness sessions about the importance of organ transplantation and organ donation. And they have been conducting these sessions through through a plethora of platforms, from universities to colleges to corporates to hospitals. And it is your tireless efforts that make this possible. And we thank you so much for facilitating this webinar, of course. It's been quite quite the experience for all of us present here. So yes, here we would like to end the webinar and hand over the floor to you, ma'am. Sunaina ma'am and Sandeep sir, if you'd like to say some concluding remarks.
Thank you so much, Dr. Atawar. You took out so much of time. And I have to tell you, Dr. Atawar was very excited when I told him, I asked him if he would like to, give this talk. And he was so excited, and I was quite shocked. So I said, "Oh, great! That he's very excited about it." So I'm sure he inspired a lot of you. And thank you so much, everybody, for joining us, and thank you so much, Dr. Atawar, and MSAI, of course, always ready to do a lot of webinars and seminars with us.
Yes, ma'am. But before we leave, could we please take a picture with all our participants?
Sure, absolutely. You know what's so interesting, and I think I must tell you this. I hate giving lectures in medical conferences because I know nobody's listening. Nobody's listening. And this is so sad. So, I realized very early on in my life, the best contribution of your time would be to speak to young minds and, fire their enthusiasm. And to me, there is no greater opportunity than speaking to young, impressionable people, because we never had this privilege. We never had the opportunity, and all of our teachers, while many of them were brilliant and continue to be, I continue to respect a lot of them, they did not have the power of communication. And in medicine, I think one of the biggest challenges that we continue to have, because I can assure you 50-60% of your work is going to be communication. And that is, you do not have a single course on communication throughout your medical school. They do not teach you how to communicate, and you have to have a natural flair for this. I was one of the quieter people in my class, but over a period of time, the challenges of practicing medicine have taught me to focus on many of these things. So the last tip that I want to let all of you know is practice